Well, hello and welcome back again. This will begin chapter 15. So this will be lecture 1 for chapter 15. I think what I will do on Moodle is rather than numbering lectures, 1 through 20, 30, 40, however many we happen to generate by the end of the semester, I think what I'll do is do them by chapters. So for this one, I'll do chapter 15, lecture 1, chapter 15, lecture 2, and so forth. And they'll all be in chronological order, so you should be able to find them pretty easy and keep track of them. Okay, we're going to begin chapter 15, and let me enlarge this so that you can get a maximal image on your screen there. The objectives of this chapter, of course, there's many objectives. Let me plug in here before my battery goes dead. The major objective of this chapter really is regulation of blood pressure. Included in this chapter, though, we'll do a survey of the major structure of the histology, of the major blood vessels in the body, arteries, arterioles, capillaries, and so forth. And we'll look at those factors that regulate blood pressure, and there will be some intrinsic mechanisms that blood vessels have. Of course, neural regulation, hormonal regulation, and then finally regulation by metabolites. So, at any rate, to get started, this first image at the top of chapter 15, it shows a cross section. It's a micrograph of an artery. I thought it was really neat because, and I've noted down below here that these are red blood cells in here, and I think they provide a pretty good context for the size of this vessel. It is important to pay attention to this. When we get to the capillaries, you'll probably notice that capillaries, in many capillaries in the body, the red blood cells actually line up, and they pretty much go through single file. That's how small capillaries are. They're like 7 to 10 microns in diameter. So this artery is pretty large. And of course, this isn't one of the largest arteries in the body. So you can see the mass of red blood cells that are being moved by this vessel. Okay? All right. Overview, to put things in context. This initial cartoon is an overview of the cardiovascular system. They've shown the heart, the right and the left sides of the heart, in this case, in series. So the right side, you can see, is blood's going to be ejected out of the right ventricle into the pulmonary trunk. It'll pass through the lungs, millions and billions of capillaries where there's oxygen and CO2 exchange. Blood gets returned to the left side of the heart through the AV valve on the left side. That's the mitral valve. Then during contraction, during systole, the blood's ejected into the aorta. And of course, this supplies blood to the systemic part of the cardiovascular system. Just to kind of trace through this quickly to put things in context again, this first part here is showing blood being ejected into the aorta. The dashed lines, I've superimposed a couple of things on here to draw your attention to. The dashed line represents this vessel pulsing out in response to systole. When the heart ejects, let's say 70, 80 mils of blood into the aorta, it'll pulse outward during systole. Then as the heart relaxes during diastole, the vessel will recoil back down to its original shape. And again, this doesn't involve any muscular contraction. It's just recoil of the elastic fibers that are within the vessel. It also illustrates, as she's indicated up above, this is how the arteries function as a pressure reservoir, because even during diastole, this vessel is going to be recoiling back down on the blood and generating a greater pressure in this region than downstream. So blood flows when there's a pressure difference. So even though the heart is relaxing during diastole, if I just pick a point here, P1 is going to be greater here than P2 downstream. This represents that diastolic runoff that I've been referring to or have referred to multiple times. As the blood moves through the circulatory system, the pressure at any one point in any one of these distributing vessels, distributing arteries here, is going to depend upon, first of all, the pressure generated by the heart, but it's also going to be as a result of the amount of resistance downstream. So if I were to pick this vessel right here, okay, pressure would be generated by the heart pushing the blood through the system, but the level of resistance downstream, if there's a lot of resistance, then the pressure will go up upstream. So we'll spend a lot of time focusing on the physiological regulation of the arterioles, their level of constriction and dilation. And again, for the most part, constriction is mediated neurologically. Dilation is a consequence of a lack of neural stimulation, although there's metabolic control that I'll get into shortly. I underscored this variable resistance here because over here they've shown the heart in series. Over here, though, you'll notice things are in parallel. That's kind of important to note that. In fact, one of the last series of cartoons that we'll cover today shows this very phenomenon that you're looking at right here, only they're looking at the actual blood flow through capillaries distal to an arteriole. These little clamps with adjustable screws are just meant to represent, metaphorically, you know, if we put a clamp on there and turn it down, it's analogous to vasoconstriction in response to sympathetic stimulation. So it's variable resistance, it's differential. It means that this one could be exhibiting a lot of resistance. The one right next to it might not have any resistance at all. It might be dilating. That's kind of important because we only have a total of maybe 5 liters of blood. So if all of these were to open up simultaneously, our blood pressure would drop so precipitously that we would probably just pass out before we even hit the floor. So that'll turn out to be an important idea to think about as we go along. The capillaries I've indicated here, that is the microcirculation. Later we'll talk about microcirculation and capillary exchange of nutrients and waste. So over here is just some cells representing nutrient uptake, waste disposal. And again, we'll do that toward the end of this chapter, toward the end of chapter 15. Again, this variable resistance can be regulated by the autonomic nervous system, but also by local metabolites. I've indicated a few, but not all of them here. Nitric oxide is actually produced by the endothelial cells of blood vessels. Oxygen and CO2, of course, we have a pretty good idea where those are coming from. The hydrogen ion is a waste product, but there's other metabolites that regulate this level of resistance that we'll talk about shortly. We'll spend a lot of time on the autonomic nervous system, primarily norepinephrine as a neurotransmitter of sympathetic postganglionic fibers. As the semester goes, we'll introduce a variety of hormones. Epinephrine will come up right away. Epinephrine is produced by the adrenal medulla. Very similar to norepinephrine. In fact, it's only one metabolic conversion away. But it's in the circulation, so we consider it a classic circulating hormone. Others that I'll talk about, vasopressin, angiotensin II. We'll be talking about the kidneys, and those hormones will come up in the context of our discussions on the kidney. Down below, a similar type cartoon that you saw with the artery up above, this dashed line, okay? Now again, the pressure coming through the veins, remember, is much less than the pressure up above. We've looked at pulse pressure waves in the circulatory system, and we'll be doing that again, but the pressure drops precipitously down here. But nevertheless, the veins are capable, because they have a lot of compliance and a much thinner muscle coat than do the arteries. As more fluid moves into them, they can expand out to accommodate it. So veins are very accommodating. And again, if I were to suddenly subject myself to maybe a half a liter infusion of fluid right now, most of that fluid would go to the venous side of the circulation. It would expand like they're showing with the dashed line here. It would accommodate the fluid. And because it can accommodate the fluid and function just like a water reservoir that sits up on the top of the hill here, coming into Pocatello, we sometimes refer to the veins, because they're expandable and so forth, as a volume reservoir. So each individual venous system can function as a volume reservoir. Okay, all right. This final thing, each side of the heart functions as an independent pump. That's true. They function pretty much in concert, though. There is actual timing differences, subtle timing differences between the left and the right sides of the heart, believe it or not. They don't contract and relax perfectly in unison, but nevertheless, they're very highly orchestrated. So we'll assume that they're pretty close in time to each other. Okay, a survey of some of these of the major vessels. This first cartoon is a panel starting with a large artery like the aorta, and then proceeding through smaller arteries and arterial. That's all it means is little artery. Capillaries. Capillaries coalesce into venules, which are little veins, then larger veins, and of course the largest ones are the vena cava, which return blood to the right atrium. Right atrium. Sorry. Now, you don't need to memorize the precise numbers on vessel sizes, but it is important to have a feel for vessel sizes, particularly in diameter. We're not going to worry about length because remember that doesn't change. But it is important to have a sense of the difference in vessel diameters. And also, the most important thing to appreciate about these various vessels is the contribution that each of the tissue types makes to that vessel. So you'll notice here that across the top, we've got, of course, diameter, mean wall thickness, but then over here are some histological features that are really important. We've got the endothelium, and the endothelium is nothing more than a single layer of cells, and as I'm indicated here, it's a type of epithelium, above or upon. And again, it's the same throughout the entire cardiovascular system. Endothelial cells line the heart, arteries, arterioles, capillaries, venules, and veins. These other components, though, change the extent that they are developed within these various vessels. So the first thing we see here is elastic tissue, and then smooth muscle, and then fibrous tissue. Now, in cross-section, each of these vessels, the internal lining, that is a single layer of epithelial cells called the endothelium, thick. These cells rest on a basement membrane, and because it's internal, it's sometimes referred to as the tunica intima. Tunica refers to a coat. So the internal lining is sometimes referred to as a tunica intima. The next layer out is a layer of smooth muscle, and it varies tremendously in thickness, as you'll see here. Because turns out to be the middle layer, it's the middle coat, so we sometimes call it the tunica media. And I'll talk about the tone and the physiological regulation shortly. Surrounding all these vessels is an external connective tissue coat. So this would be the fibrous tissue. And because it's external, sometimes it's called the tunica externa. So if you take a histology course, they'll expose you very quickly to tunica intima, tunica media, tunica externa. If you look down here, and this is the important part to understand about all these vessels, if you look at the components that make up each of these large vessels. So let's start with an artery. You can see arteries have a lot of elastic tissue compared to arterioles and all the other vessels except the veins. Now, an artery like the aorta, remember I said when the heart contracts and ejects like 70 mils of blood into it, it stretches out, but then it recoils back down during diastole. This elastic tissue that's what provides the recoil. So you can see that's providing to that pressure function that these arteries can play. If you skip on down here in veins, you'll see they've got quite a bit of elastic tissue too. That allows them to function as volume reservoirs. Okay? We don't have a lot of elastic tissue around arterioles, and of course there's none around capillaries, and very little or none around venules. We only start to see it again in somewhat larger veins and in the vena cava. The muscle layer, we can see it's very thick around an artery, okay? It's not as thick around an arteriole, but notice that there's no elastic tissue. Now, that turns out to be an important idea or concept because the arterioles, these are the resistance vessels. And when the smooth muscle contracts around the arterioles, they're going to cause a tremendous increase in resistance, or can cause an increase in resistance, and pressure will go up as a consequence of that. So the muscle layer, relative to the diameter, though, is really quite large. Capillaries, again, are just a single layer of endothelial cells resting on a basement membrane. There's essentially no elastic tissue, smooth muscle tissue. And even though they've got fibrous tissue 0 here, there is connective tissue that forms the basement membrane around these cells. It's just, they're emphasizing here that it's very thin for the typical capillary. The venules, they start to develop, because they're larger vessels, they start to develop some connective tissue, fibrous connective tissue. And again, it represents a significant portion of the outer coat, the tunica externa, in a vein. So it is important to keep in mind the relative contribution that elastic and smooth muscle tissue, I'd have to argue these are probably the most important, because the capillary just is nothing but a tube of endothelial cells. But the muscle and elastic tissue, those are the two tissue types which we really need to think about and the role that they play in the physiology of these vessels. Finally, the veins outnumber the arteries and lie closer to the surface of the body. So if you're unfortunate enough to be developing varicose veins like in the back of your legs, these are, again, these are more at the surface of the body. They're usually not harmful, they're just unsightly. So at any rate, we'll have some more to say about that as we go along. Okay. Let's see if I can get this to respond. Okay. I captured this micrograph of a cross section through an artery and a neighboring vein to show a couple things. First of all, the arteries and veins in many cases run side by side. But the thing I was trying to show here is the relative thickness of the tunica media in an artery as opposed to a vein. The overall diameter of these two vessels is very similar, but look how thick the tunica media is here relative to the vein. And you can see the red blood cells in there again, providing some contrast, some context for the size of these vessels. This shows, again, the inner lining is the tunica intima. The muscle, that's the tunica media. The connective tissue outside is the tunica externa. So the externa, all that does is provide a connective tissue coat to basically hold things together. Now, the capillaries. We're going to first look at a typical capillary bed. I've got some things I want to say about the physiology of capillary beds, and I also want to give you a clinical example to try to get you excited about studying the microcirculation and capillaries in general. There's 3 cartoons here. The first one shows a typical artistic rendition of a capillary bed showing the types of vessels that communicate between the arterial and the venous side of a circulatory system. And then over here, they show different states of blood flow through a capillary bed. Now, let's first look at this figure. Here's an arteriole bringing blood into a capillary bed. Now, a true capillary usually has a single smooth muscle cell that wraps around the entrance to the vessel. And that basically defines a true capillary. The capillary, again, is just a single layer of endothelial cells thick. And here they are branching to form a network of pathways. Again, teleologically, all of these cells need to be about 50 or 60 microns from a capillary. So the capillaries branch teleologically for the purpose of providing nutrients and removing waste to all of these cells. Over here, I can see that they coalesce, they come together, and starts to form a larger vessel, a vein, or a small vein, which we call a venule. Once more, the red blood cells would basically move through a capillary like this, pretty much single file. They line up like almost like a stack of pennies, a roll of pennies that you might put in a penny wrapper. They just go through single file. The venules begin to get larger and larger in diameter. They start to acquire smooth muscle and more connective tissue, in which case we classify them as veins. But it's a gradual transition between the capillaries, the venules, and the veins. Now, illustrated in this cartoon, I see at least 3 different pathways here. An arteriole can give rise to a capillary in which there's that pre-capillary sphincter, that single smooth muscle cell, I'm sorry. And of course, the blood could pass through this tube to the venule side. Another way that the blood can get to the venule side is through one of two types of bypass vessels. This first bypass vessel is called a metarteriole. Now, you'll notice that the capillaries branch off of the metarteriole. The metarteriole doesn't have any muscle regulating flow through it. The capillaries, which branch off of it, each one of these, and I'll use my arrow here to point to, for example, here's a pre-capillary sphincter. Here's another one that's a single smooth muscle cell that wraps around the entrance to the capillary. When the pre-capillary sphincters contract, that give rise to the true capillaries, what you see is something like over here on the right. Let me go to the bottom figure. If the pre-capillary sphincters constrict, then the blood simply flows through this meta-arteriole directly from the arteriole to the venous side. It just shunts the blood directly to the veins. And for a moment, there's no blood flowing through these capillaries. Now, when the pre-capillary sphincters relax and allow blood to pass through, which is what you see up above, if all of the pre-capillary sphincters are open, like what they're showing in figure A, then you've got blood coursing through all this network of capillaries. Now, I put a term here called vasomotion. All it means is intermittent blood flow. Blood flow does not flow through a capillary, even a single tissue type, like muscle or kidney. It doesn't flow through all the millions of capillaries all at once and then shut down all at once. Different regions of the tissue will exhibit varying levels of control over the blood flow through the capillaries. Again, when we used to do laboratories on this, I used to use frogs, the webbed foot of a frog. We'd have the students put the frog's foot on the stage of a dissecting microscope and then just pull its toes apart, like I'm pulling my fingers apart right now. And the webbing is so thin that the light shines through it. You can actually see these capillaries, and you can actually watch the individual red blood cells race through these capillaries. And again, it just reminds me of a roll of pennies or quarters passing through a tube like this. But the blood might flow real quickly, like through this section right here for a minute or two, and then stop. And then at the same time, it might be flowing really quickly through the tube up above. So there's intermittent blood flow. And in part, the flow is according to need. Teleologically, when there's a need for increased flow, like let's say in this region right in here, like these cells aren't getting adequate oxygenation, they're generating lots of waste products like hydrogen ions and so forth, this capillary will relax and allow the blood to pass through. And again, teleology is a good place to start, but we want to explain why the flow is intermittent. We'll do that by explaining the underlying physiological mechanisms for that, okay? So, vasomotion, all right? The final one is something called an arteriovenous bypass. These are actually more appropriately called arteriovenous anastomosis. And I have some diagrams and I've typed this all out for you. An anastomosis is nothing more than a bringing together of an artery and a vein, a bringing together of two things. Arterio, the prefix, refers to the artery, the connector, and then the suffix venous, arteriovenous, refers to arteriovenous pathway. Anastomosis is an important word to know because the arteriovenous anastomosis do not contribute to any of the capillary blood flow. They are strictly bypass vessels. You and I have tons of these in glabrous skin and smooth skin like fingertips and the nose and the ears and so forth. They're thermoregulatory organs. And I want to give you some examples of that now and also point out a clinical syndrome. And I'm doing this to show you why you want to understand something about blood flow, why you want to understand something about the different types of adrenergic receptors that regulate blood flow. It has tremendous clinical and physiological significance, okay? I give you this cartoon because I thought it showed really nicely flow, vasomotion. Here's an artery, arteriole, small artery. Pre-capillary sphincters, the muscle has contracted and closed off blood flow through these capillaries. But downstream, they've relaxed and opened up, and you got blood flowing through these capillaries and into the venules. So once again, the meta-arteriole is just a shunt. Okay, there's nothing controlling blood flow through it. In fact, let me back up here. The difference between the meta-arteriole and the arteriovenous anastomosis is that the arteriovenous anastomosis can be highly regulated by the autonomic nervous system. In fact, it's all sympathetically regulated, and I'll explain that to you now. Okay, so all right. The vascular supply to the skin, your and my skin, actually has two different types of resistance vessels. There are the classic arterioles, and then there's another resistance vessel system that's called an arteriovenous anastomosis, or shunt. So I've listed these two here for you. Here's a cartoon. This would be a cross-section through the skin, like in the palms of the hand. The epidermis is a layer of cells at the basement of membrane, like right here. Cells are dividing and moving upward toward the surface of the body, and they're continually sloughing off. So, and this continues throughout life. In fact, our beds are probably full of a lot of dead keratinized cells that have sloughed off of our bodies. The epithelium of the skin, which is epidermis, is continually replacing itself. Underneath that is some connective tissue. And again, this is the below the epidermis. This is the dermis. And in the dermis, you can see that there's a vascular system, arteries, arterioles, capillaries, venules, and veins. Okay. So at the top, I've got an artery. This might be an arteriole giving rise to a capillary bed, which then drains into a venous system. But in addition to that, classic arteriole, there's also present these arteriovenous anastomoses. So here's an artery, actually a small arteriole, which has a direct conduit to some venules on the other side. Now, these anastomoses, connections between arteries and veins, okay, first of all, they lack capillaries. Let me back up and show you this cartoon again. You can see this structure here, okay? There's no communication, there's no gas and nutrient exchange going on here. Okay, back to this figure. There are no capillaries. It's a direct conduit between arteries and veins, and therefore they do not contribute to capillary blood flow. What these structures do for us is to function as thermoregulatory organs. Now, if you can envision this being the surface of the palms of the hand or the fingertips, for example, when there's a maximal blood flow to the skin, it can result in a lot of radiant heat loss. When the vessels constrict, like if these arterioles constrict here, then that reduces blood flow to the surface of the body. It shunts the blood, if you will, to the core. It's how we, in part, thermoregulate. It's only one of the ways we do it, but in the context of the cardiovascular system, that's what we'll emphasize now. So an arteriovenous anastomosis is a thermoregulatory organ. Why do you care? Well, look at this cartoon here, okay? They're using the earlobe here. Epidermis, dermis. Here's an arteriole coming in, branching into a capillary network, draining off into venules. It's regulated by the autonomic nervous system. There's norepinephrine being released. If norepinephrine causes constriction, that'll reduce blood flow through this capillary bed. That'll result in a reduction in the amount of warm blood coming near the surface of the body and reduce heat loss. Okay? Next to it, in the dermis, is this arteriovenous anastomosis, or anastomosis, singular, anastomosis, anastomoses would be plural. Histologically, you get some names like glomus body. We'll see a glomus body when we get to the respiratory system as well. It's just a histological. They refer to that because the histologists, when they made sections and stained these tissues and cells, that's how it looked to them. So that's why they did that. Anyway, I'll call them AVAs, arteriovenous anastomoses. We also thermoregulate by sweating. I won't be saying anything about that, but we have radiant heat loss and then sweating as well. Now, the arteriovenous anastomosis, I provided about 3 sentences up here to summarize this for you. These structures are normally exposed to a rather high level of sympathetic stimulation. That means that there's increased sympathetic vasoconstriction almost all the time. So they're partially constricted, reducing blood flow. Now, when they're exposed to cold, like if it's wintertime and I walk outside, my ears, oh man, my ears hurt, they're getting cold, okay? They just basically shut down and close completely. So it reduces blood flow to the skin. You also get some constriction of these arterioles over here as well. So the blood gets shunted away from the surface of the skin. When it's real hot outside, like the last couple of weeks, we've had 95 and 100 degree days. When that happens, they dilate. Again, under most normal conditions where we're not real hot or real cold, they're partly constricted, reducing blood flow. It doesn't stop, but it reduces it. When we're real hot, the body of the ambient temperature around the body is real hot. These will dilate, allow more blood to move through. More heat is lost through just radiation, okay? Cold, they essentially shut down, okay? And shunt the blood, keep the blood into the core of the body. Why do you care? Well, there's a condition called Radod Phenomenon. It's also been broken down into Raynaud's disease now. The difference is one of severity. I'm just going to describe Raynaud syndrome. If you're interested in this, there's an absolute wealth of literature on the subject. This one paper by Wigley and Flavihan, it's an excellent review. It's just a superb summary of the subject, but I won't be testing you on the papers. It's simply there. If you're interested, you can read about that. You may have a relative that has Raynaud's phenomenon. My mother had Raynaud phenomenon. She would be sitting around the summertime on a relatively nice day that I thought was nice, and her fingers would turn white. She'd start rubbing her hands because they hurt. The reason for asking you why should we care about this is that in areas of our bodies, specific areas like fingers, toes, tips of the nose, earlobes, even nipples, are rich in arteriovenous anastomoses. When these are overreactive, they're almost shut down most of the time anyway, but when they become overactive and just close at normal body temperatures, it can really shut down blood flow to the skin to such an extent that the skin becomes hypoxic, and it'll actually activate pain fibers and it hurts. And again, the intensity of the pain varies from one subject to another, but it can be really painful. I can remember my mother just wincing and rubbing her fingers together. In severe cases in Raynaud's disease, and it's a disease when it's usually associated with another underlying condition. Raynaud phenomenon, there's usually no other association with it. Disease, it's often associated sometimes with other autoimmune type diseases, but at any rate, can actually lead to necrosis of the skin. I'll show you a couple of images here of people that are having a response that have Raynaud phenomenon. This picture on the left here, the person's hand, you can see how white the fingertips are. There's such intense vasoconstriction that the fingers at first, that's why I've said initial response, they basically turn white because of the lack of blood flow. These kinds of responses usually varies again from one person to another. It might last 20 minutes or so. And then the blood will start to flow into the skin again. When it does, then the fingertips kind of turn purplish red in color. I show you these two pictures because the one review written by experts in the field to diagnose this, of all the sophisticated ways of diagnosing disease, as they point out in their review, the most straightforward way is just, inspecting the patient, visual inspection. So they'll usually exhibit this initial response where their fingers get blanched at the pallor and they turn white. And then subsequent to that, when they rub them and get some warmth on their hands, they turn purplish in color. So I'll show you some other figures of that. This is really difficult to treat. And again, The number one treatment is for if you have a patient like this, is you tell them to avoid the cold, wear gloves, try to keep their bodies warm. And again, that's to show you how specific they are about this. In the summertime, a person like this probably wouldn't want to come in from the outside where it was 95 to 100 and rush into a cold air-conditioned room. That'd be enough to bring this on, okay, in a person that had Radod phenomenon. At any rate, reducing cold, stress, and of course, no smoking. I'll be on a soapbox all semester about anti-smoking. It's bad for your eyes, it's bad for your heart, it's bad for everything. Lungs, obviously, it's bad for, but it's just there's just no organ system that smoking is beneficial for. Smoking, if it doesn't cause Raynaud, it's definitely been shown to aggravate the situation. So if you have a relative that has Raynauds and they're smoking, do your best to try to get them to stop. Are there any drug interventions, pharmaceutical interventions? Well, there's a number of those, and I only decided to tell you about one. And the reason I'm doing it is because I've talked about it in this class. One that's showing a lot of promise is a dihydropyridine calcium channel blocker. When we talked about the underlying basis for cardiac muscle contraction, remember I talked about dihydropyridine receptors and ryanodine receptors in the sarcoplasmic reticulum. There's a variety of agents that can block these calcium channels. And for some patients, not all of course, but for some patients it's showing a lot of promise. But it's very difficult to treat. And again, most patients never even seek medical help because it's not life-threatening. And unless it gets extremely painful, they usually don't go in. The percentage of people that have this, I think it's estimated like 3 and 4% of the population may have this. It's probably higher than that. It's like diabetes. Diabetes is epidemic in this country, if not in the world. And the thing that we're truly concerned about is the people that are under the radar that haven't been diagnosed with diabetes yet. So at any rate, when I get to that, I'll have more to say about the statistics of that, or the demographics. A couple more pictures of this. Here's one, again, showing just portions of the fingers turning white. Interestingly, the thumbs are often spared. I know this last person, their thumbs were even affected by this. But in the great majority of cases with Radod phenomenon, the thumbs are spared. But again, that just selective regions where you get intense vasospasm of the arteriovenous anastomosis, as well as the arteries that lead to the skin. There's one showing just a single fingertip. This is usually in non-hairy or what's glabrous skin. So again, as I've said, feet, palms of the hands, ears, nose, especially fingers and toes, are very rich in AVAs. They also have the regular arterial capillary, venule systems. The arteriovenous anastomoses are regulated only by sympathetic vasoconstrictor fibers. Now, I point that out to you because some of the other systems are regulated by local metabolites. Hormones figure into this. But the anastomoses appear to be only regulated by the sympathetic nervous system. Other areas of the body, like haired areas that are non-glabrous, there's few or no AVAs. And in these regions, there's both sympathetic vasoconstrictor and vasodilator fibers that regulate blood flow. Almost all of these fibers exhibit a basal level of tone. I've said here that sympathetic fibers exhibit a basal level of tonic stimulation at neutral temperatures, but the dilatory fibers have to be actually activated when the ambient temperature goes way up. And again, that's worth pointing out because if you go into clinical medicine and you're exposed to somebody with Raynaud's phenomenon or Raynaud's disease, they have a heightened sensitivity to sympathetic stimulation, okay? You and I don't have Raynaud's phenomenon, but the AVAs, for example, in my fingertips are partially constricted already in response to sympathetic activation of the smooth muscle around those vessels. But somebody with Raynaud's, they have enhanced sensitivity. There's either a greater sensitivity of the cell to norepinephrine, or there's more epinephrine being released on them, or there's other underlying mechanisms that interfere with regulating the level of vasoconstriction. Okay, last figure shows the level of heat conduction at the surface of the body. Down below, we've got ambient or environmental temperature, varying from 50 up to over 100 degrees. And you can see as the temperature diminishes, there's vasoconstriction. We have much less heat loss conducted away from the body. When we get real warm, like on a 100-degree day, vessels dilate, there's increased blood flow to the surface of the body, vasodilation, and enormous amount of heat loss as a consequence of convective currents taking the heat away. Okay, all right. I want to move now to the capillaries and say something about the specific types of capillaries. The reason I want to do that is that as we talk about the different organ systems, be it lungs, kidney, gastrointestinal tract, endocrine organs like the pancreas, the type of capillaries that supply these tissues can exhibit quite a bit of variation. In order to pull that together and categorize it and have it make a little bit of sense so we can somehow keep track of it, we can usually think of capillaries, we can categorize them according to three specific types histologically. This first one's called a continuous capillary. The second one's a fenestrated. A fenestration is like a window, if you will. The windows in this building would be fenestrations. And then finally, we have something called a sinusoidal capillary, a discontinuous capillary. Above each of these, I've tried to give you some organs or tissues where you would find each type of capillary. So let's go through these in brief. The first one's called a continuous capillary. Now, the reason it's called a continuous type capillary is that the endothelial cells that make up the capillary, first of all, there's no fenestrations or windows in the tube. The individual endothelial cells are anchored all along their sides to each other. So in other words, this here is part of a cell. This over here is part of a cell. This intercellular junction, inter means between. So between the two cells, they're completely anchored all along their margins. So materials can't leak through the tubes unless they're small and lipophilic, and they can't leak in between the various endothelial cells. So they call them continuous type capillaries. These type of capillaries, the only way that materials can get from the inside to the outside or the outside in is if they're, again, small and lipophilic, like gases like CO2 and oxygen, or if there are transport mechanisms for them to move them back and forth across the membranes of these individual cells. So they're continuous. Where you find capillaries like this, number one, probably should have put that first, is the brain. That's what forms part of the blood-brain barrier. Okay, so the only thing that get in and out of the capillaries of your and my brain, small lipophilic things or things for which there are transport processes. Why do we care? Well, if you're going into medicine, a lot of medicine is based on pharmacology. When pharmaceutical companies generate drugs to alter like neural function, like depression, these agents have to either be able to diffuse through these membranes, or they have to take advantage of transport processes that are already there. So it can be a real challenge for the pharmaceutical industry. They can find drugs, chemicals that'll alter nerve function, but now they got to find some way of getting it out of the capillaries and so that it can gain access to the neurons of the central nervous system. You also find these in muscle, skeletal muscle, exocrine organs like sweat glands, and you also find them in the lungs. So again, we'll have more to say about those when we look at each individual tissue type. The second one, same basic cartoon, but the difference here, the major difference, in fact, if I took this cartoon, copied it over and said, okay, I'm going to illustrate to you a fenestrated capillary now, the big difference really is that there are windows that are covered by a thin diaphragm between the fluid inside the capillary and the extracellular fluid on the outside. Down below, the artist has taken and enlarged this a little bit. And again, you can basically think of it as a room with a window. Now, this has an open fenestration. This has a fenestration with a diaphragm. All that means is like there's like a screen. In fact, the way that I usually think of fenestrations in capillaries is if I open the glass window in my room at home, but I have a screen that's still there because I don't want the mosquitoes and flies coming in, the screen would be analogous to this thin diaphragm. In fact, in most cases, you'll see that rather than just an open fenestration. An open fenestration, this is starting to smack of the final capillary that I'll talk about next. So it's a meshwork of connective tissue, like a screen, and it basically functions as like a filter to sieve out things that are maybe too small or too big that shouldn't be gaining access to the outside or the inside. Okay? These types of capillaries you'll find in endocrine tissues like the pancreas. The pancreas makes hormones like insulin. Insulin has a molecular weight of about 6,500. Well, now a molecule like that would never be able to just diffuse into a continuous or tight capillary like this. So in order to get the hormone from the extracellular fluids around the cells that make the insulin and get it into the capillaries so it can course throughout our bodies and play its role in regulating glucose homeostasis, we basically poke holes in the capillary plasma membranes and allow entrance for the hormones to gain access to the systemic circulation. So endocrine glands, we'll see these big time when we talk about the kidneys and also when we talk about the gastrointestinal system. So it's important to understand the type of capillaries that are there to understand organ function. Okay? Finally, we've got something called a sinusoidal or discontinuous capillary. And I can see that the authors have said sinusoidal. Gee, that might not make a lot of sense. Let's call it discontinuous. Well, again, if I took this cartoon and said, well, now I'm going to illustrate the third type of capillary, how would I do that? Well, the first thing I would do is take this figure and I would take these cells like cell 1 and cell 2 here, and I'd pull them apart. So see these gaps? Those are gaps in between individual endothelial cells that make up the blood vessel. In addition to that, you've got these huge openings, huge windows. Instead of having a little 2-foot square window, let's say, we got a 4-foot square window now. So the barrier between the fluid inside the capillary and that outside the capillary is reduced to its very minimum. What this does is it results in large molecules, almost up to the size of cells, being able to leak out of these capillaries. So for the most part, the cells stay behind, but really large molecules can now leak out of capillaries into the extracellular space around this tube. In a tissue like the liver, again, when we get to the gastrointestinal tract, remember, most of the blood flows through that portal system from the GI tract and goes to the liver. That's the first place it goes. As it passes through the liver, lots of large molecules can leak out of these types of capillaries and be exposed to the hepatocytes, the liver cells. The liver cells can do their metabolic thing, and we'll get to that later on. But if they couldn't do that, then the liver could not perform their function of basically cleaning up the blood before it's passed on into the systemic circulatory, the rest of the systemic circulatory system. So they're discontinuous, large fenestrations. Liver, you see these in bone marrow and also the spleen. Last thing I want to say about this down below, I've said, the endothelial cells rest on a basement membrane, okay? Even though in the graphical representation, they show no fibrous connective tissue around capillaries, there is some connective tissue, otherwise the cells would just simply float off and separate. So there is connective tissue. But in the liver, a true basement membrane is not present. What connective tissue is there is pretty thin, and the types of proteins that make it up differ from other types of tubes. Let me read this to you. Although there are reticular fibers, and reticular just means a near regular arrangement of fibers, like a spider web, that provides support for the endothelial cells. Liver sinusoidal capillaries lack a true basement membrane. They don't express type 4 collagen. That's what the histologists say has to be present to have a true basement membrane. The fenestrations also lack a diaphragm. So again, it provides free access. For a capillary and an endocrine gland like the pancreas, you might see these fenestrated screen-like coverings, but you don't see that in the liver, and there's no true basement membrane. However, what can happen with excessive alcohol intake, years of alcohol intake can lead to something called fibrosis of the liver. Maybe you've heard of it. It's alcoholic fibrosis. It leads to the loss of the fenestrations and formation of these of a true basement membrane. So you have less window-like openings for a severe alcoholic that has fibrosis of the liver. You can be a severe alcoholic and not have fibrosis. But for one that has fibrosis of the liver, there'd be less fenestrations, and there would be an extensive development of the connective tissue around the capillaries. So they actually do start to form a true basement membrane. Both of these impair the communication between the capillary lumen and the fluid around the capillaries. In other words, the liver cannot now take up things from the blood. It can't inactivate them. It can't, metabolize them. And as a consequence, liver function is impaired. And again, it's one of liver failures, one of the fatal consequences of fibrosis in the liver. Okay. I wanted to show you a picture of a fenestrated capillary. This one is from the kidneys. This is a renal capillary. If you look closely at this, you see all these little look like holes. This is a cross section through a capillary. All those little holes are fenestrations. When we get to the renal system, and I talk about glomerular filtration, it won't be hard to imagine why everything but red blood cell, all blood cells and large macromolecules are freely filtered across glomerular capillaries in the kidneys. It won't be hard to understand why we say that the kidneys filter the blood and then they eliminate waste products and retain essential nutrients and so forth. So again, this is a cross-section of a renal capillary. Those are fenestrations. Okay. One last thing about capillaries. Some of them exhibit associated cells called pericytes. Captured a simple cartoon that would be indicative of what's going on in the brain. This would be a continuous capillary, or arterial, I'm sorry, would have continuous capillaries as well though. And then these are astrocytes. These are nerve cells. I'll talk about astrocytes later. They're sometimes called nerve cells for the nervous system. They play a role in synaptic communication. They regulate nerve cell function, but they don't conduct action potentials. At any rate, these pericytes, and again, to break the word down for you, the prefix peri, all that means is around. I could call these peritubular cells and be correct. They would just mean around the tube. It's behind a cell, so they call them pericytes. They have a contractile function when present, so they'll sometimes contract around capillaries, reduce their diameters, and reduce blood flow. So they can physically, simply by being present, they can limit capillary exchange. And again, they contribute to this blood-brain barrier that we sometimes refer to. So the brain has continuous capillaries. It also has these cells which wrap around and further limit what can get in and out of these capillaries. You also have this kind of a barrier in the back of the eye, in the retina. Why do you care? Reduced pericytes is one of the hallmarks, clinical hallmarks in diabetic retinopathy. People with diabetes frequently lose their eyesight and go blind. One of the histological manifestations of that is you have reduced pericytes around the capillaries within the retina of the eye. It's a hallmark of that disease. Okay. All right. Moving on to the venous side now. Okay. An overview, to show the cardiovascular system. Okay. Arteries take blood away from the heart. Veins bring the blood back. So we'd have the capillaries coalesce into venules, and then small veins and larger veins until we have the superior and inferior vena cava, bringing blood back to the right side of the heart, at least for the systemic circulation. In the venous system, beginning not in the venules, but in the somewhat larger veins, you have one-way valves, which prevent the backflow of blood. So as the blood moves through the veins and is squeezed, there's a muscle pump like in our legs, which we'll talk about next, which in addition to the pressure gradients tends to move the blood back up toward the heart. The veins prevent the backward flow of blood backwards. When these valves break down, it results in varicose veins. And again, most of us, if we spend a lot of time standing on our feet, if you are going to the pharmacy, you're going to spend a lot of time standing on your feet. If you go into teaching, there's no way to avoid that. Or there was no way to avoid it until this coronavirus pandemic. But standing in place like that, hour after hour, day after day, week after week, these veins, the stress on them, they break down. And then it becomes a positive feedback effect, because like if this valve here at the top breaks down, then you've got a larger column of blood exerting hydrostatic pressure by gravity down on the veins below it. So at any rate, there's a pressure gradient that moves the blood through the veins, but there's also, the muscles around the veins, simply by walking. It reduces the pressure and squeezes the blood back up toward the heart. So walking increases vascular return to the heart, increases the return of blood to the heart, and plays a big role in regulating the pressure gradients. So if you have to stand in place, it's a good idea to shuffle around, squeeze the muscles in your legs, because it facilitates venous return to the heart. There's also the respiratory pump, which I have mentioned. Every time we inhale and exhale, when we inhale, it reduces pressure inside the thoracic cavity. That causes the pressure to go down. When the diaphragm compresses the abdominal muscles, that facilitates movement of blood back to the heart. So we've got a skeletal muscle pump, and we have a respiratory pump that facilitates the movement of blood back to the heart. I captured, again, another cartoon down below, actually, series of cartoons to illustrate the relative contribution of the elastic tissue and the muscle tissue in each of these vessels. And again, I like this one because it illustrates a little more of a gradual change. Again, the elastic tissue, big time in the aorta, the arteries, much less in the veins, a little more in the vena cava, some in the arterioles, terminal arterioles, although again, the take-home point in these terminal arterioles, lots of smooth muscle, but not much else. Just enough connective tissue and elastic tissue to hold things together. Okay? So again, you want to study the relative contribution that the muscle and the elastic tissue makes to each of these types of vessels. These valves, and before I leave this, I want to pay attention to the notes that I've pasted on here for you. I did this just yesterday. There's no valves in the vena cava. It's only in the veins, the large veins, but the real large veins, the vena cava, no valves, neither in the superior or in the inferior vena cava. Okay. Blood pressure and its regulation. We're rapidly moving toward explaining the neurological regulation of blood pressure. This series of cartoons, again, we're beating this to death, I think, but it shows the diastolic runoff. We've taken the heart and made a simple cartoon of the ventricle and the aorta. When the ventricles contract and generates enough pressure, again, to open the semilunar valve, it ejects the blood into the aorta pulses out, which is what we're showing here. And that's going to create a pressure gradient to move the blood distally downstream. When the heart relaxes during diastole, I can see it relaxing back out and accommodating the inflow of blood, which they don't show here. But the aorta, in this case, the elasticity around it would cause it to recoil, or the elasticity would result in it recoiling back to its original dimension. That's going to create a pressure here, which will close the semilunar valve. And of course, if this valve closes, the blood can only go in one direction, and that's downstream. And again, that results in diastolic runoff. And that's that pressure reservoir function that the arteries can play. Oh, sorry. And recall, again, flow is proportional to flow is proportional to the pressure difference divided by the resistance downstream. Okay. All right, this shows the pressure wave starting at the left ventricle and shows how it diminishes in the aorta in amplitude, not in amplitude, but in pulse pressure, the difference between systolic and diastolic. And then it does show it diminishing as we proceed, as the vessels branch into smaller arteries, arterioles, and then finally into capillaries. We can see it diminishes downstream. Some descriptors. A pulse pressure is just the difference between the systolic and the diastolic. So in other words, 120/80, if I take the difference between those, a pulse pressure might be, in that case, maybe 40 millimeters mercury pressure, if I take the difference between those. The mean arterial pressure is something that we want to pay attention to because it's the driving force that creates the pressure differences downstream. The mean arterial pressure can be estimated, and I've underscored this and put it in yellow for you because it is an approximation. As in equation form, we can say that it is approximately equal to the diastolic pressure plus 1/3 the pulse pressure. And again, that's an estimation. So over here, I've got mean arterial pressure, that's the driving force. If I take some textbook values like systolic over diastolic being 120/80, if I take the systolic, which is, if I take the mean arterial pressure and calculate it as diastolic plus 1/3 the pulse pressure, the diastolic meaning 80. If I say it equals 80 plus 1/3 the pressure difference here, I come up with something about 93 millimeters of mercury pressure. And again, it's about 93 millimeters of mercury pressure. It's closest to diastolic pressure. I think that's worth pointing out because it helps us to understand the cardiac cycle. Because the duration of diastole is just about, at rest, it's about twice as long as systole. So mean arterial pressure is closer to diastolic because of that reason right there. Okay. Okay. Let me expand on this just a little bit more here and then we'll move on. The mean arterial pressure, you can see that it diminishes as we move away from the heart. And again, that's because, number one, the vessels branch. There's increased frictional resistance, both with vessel walls and within the fluid itself. So again, there's mean arterial pressure, okay? Decrease frictional resistance and vessel branching, okay? Now, we're going to talk a little bit about hypertension and hypotension. And I want to point out that you pick up different textbooks and the values vary. But as an approximation, a person is sometimes considered to have hypertension when they have a systolic of 140 over a diastolic of 90, either or both of those. They're considered hypotensive when systolic never gets above 90 and diastolic of about 60, drops all the way down to 60. Now you can have either or both of these, and it would contribute to a condition called hypertension or hypotension. I have relatives that are hypotensive. I have relatives that are hypertensive. Okay. Oops. Okay. Something I want to point out about this pulse pressure. The actual pulse pressure refers to the pressures in millimeters of mercury pressure. There is also a pulse pressure wave that moves through the vascular system, and it moves much faster than does the actual velocity of the blood. So I've captured this figure again, and over here I've said when detected at the wrist, the pulse pressure wave, okay, it occurs after ventricular contraction. And in bold, I've said, and yet the pressure wave travels about 10 times faster than the actual blood. So it's a shock wave that moves through the tubular system and then is actually reflected back. But it moves much faster than the actual velocity of the blood. And we'll have more to say about that as well as time goes on. All right. This cartoon shows in a cartoonish fashion. It illustrates those factors that affect the mean arterial pressure in the system. And I've added some text over here to draw your attention to this as well. The mean arterial pressure is the driving force that moves the fluid through this system, okay? But what regulates it? Well, in a cartoon here, we can envision the heart ejecting blood into the arterial system. So the amount of blood that would be ejected and the rate, obviously we can envision that affecting the arterial pressure. Downstream, the level of resistance is also going to affect this mean arterial pressure. So over here, I've tried to collect together and say sympathetic activity is going to regulate vessel diameter. But as we'll see, there's going to be local metabolic control. And then as we go along, we'll look at the role that different hormones play in regulating constriction and dilation of the vessel. So we're going to have lots of different overlapping factors or systems which will regulate resistance and therefore this mean arterial pressure. And I'm just reiterating again here, I'm saying, remember when we talked about the physics of blood flow, we said that resistance is proportional to 1 over the radius to the 4th power. Viscosity doesn't change, length of vessel doesn't change. What's important though is the diameter of the vessel. And as you'll see, all of these factors will regulate vessel diameter and therefore resistance to the flow downstream. In hypertension, this peripheral resistance appears to be the most important factor. Let me point out that in primary hypertension, as widespread as it is today, we really don't understand all of the factors that contribute to it. There's genetic predisposition and all kinds of things we can talk about. But we really don't understand fully what is responsible for primary hypertension. But we're pretty confident that it's an increase in peripheral resistance. That's one of the primary causes. This flow chart below is going to summarize. It says mean arterial pressure is determined by, and all of these various things. Well, first of all, blood volume is going to be explained in chapters 19 and 20. So I can't explain all of this to you in a few sentences. Can't be done. Each of these various factors, the heart as a pump, the resistance of the vessels, all of that is going to involve discussions throughout chapter 14 and 15. So to explain all of this, I can think of at least 4 different chapters that's going to have to be relied upon to explain that to you. So I will do that, but I can't do it in just a couple of sentences. It's going to take some time to get through that. This is just simply to say, okay, we're going to embark on a discussion of mean arterial pressure right now. And to do that is going to require knowledge of chapters 14, 15, and then fully in 19 and 20. Long-term regulation of blood pressure involves how much fluid is retained by the kidneys or lost by the kidneys. So that's long-term regulation of blood pressure. So I'll build this into a discussion of that as we go along. Okay. Whoops. Okay. This figure shows once again blood pressure control includes rapid responses from the cardiovascular system and slower responses by the kidneys. So again, I've got 2 chapters in the kidneys that I'll get through, but if blood volume increases in the body, like if I had a transfusion, it would cause blood pressure to go up. That would trigger, okay? It would trigger compensation by the cardiovascular system. Vessels would dilate, cardiac output would go down. There'd be a slight decrease. That would result in a drop in blood pressure. It would modulate blood pressure. The more time-dependent responses like the kidneys. Again, if I have an increase in blood volume, like a ½ liter transfusion, what my kidneys will do through time, and it will take time, okay, they'll start to excrete, okay? There'll be excretion of fluid in the urine, increased urination. That'll reduce blood volume. That'll tend to modulate the blood pressure and bring it back down. But again, it's going to require a lengthy discussion to show how changes in sympathetic stimulation to the heart, for example, cause reduced cardiac output, how reduced sympathetic stimulation of the vessels result in vasodilation to collectively cause a reduction in blood pressure. So this is an overview and will require a lengthy discussion. Whoops, okay. Blood flow through some capillary beds can be regulated by something called myogenic autoregulation. Now, that's a mouthful, but I've put it into a title because what I want to say about that is that this is independent of neural regulation. It is the response within a capillary bed to changes in things like carbon dioxide and oxygen and hydrogen ions to regulate blood flow through capillary beds. So one of the things I need to point out here is these pre-capillary sphincters, okay? They're not innervated. The smooth muscle around the arterioles they're richly innervated by sympathetic fibers, as I've said before. But those sphincters respond primarily to local metabolites. They can respond to circulating hormones for sure, but they're regulated by local metabolic conditions. So over here, I've said this is especially important, especially present in brain, cerebral, heart, coronary, and renal circulations, and also in skeletal muscle. And it may be more widespread than we once thought, but it's auto-regulated because it occurs within, it's endogenous. It's part of this capillary bed that the regulation is resulting from. So we can have local, let me back up, look at this cartoon again. I can have local changes in metabolites here that'll regulate the contraction and relaxation of the pre-capillary sphincters. Pre-capillary sphincters contract when they have adequate oxygenation. They relax when they don't have adequate oxygenation, for example. This flow chart gives two different examples of local regulation of blood flow through capillary beds. This first one says active hyperemia matches blood flow to increase metabolism. Now that's a mouthful. So what I did was I drew a box around this and said the stimulus in this case is increased metabolism. Okay, let's look at that first. If tissues exhibit increased metabolism, they'll increase the release of metabolic vasodilators like carbon dioxide, hydrogen ion. There'll be less oxygen. That'll cause the arterioles and the pre-capillary sphincters to dilate. There'll be less resistance to the flow of blood. It'll increase, and it'll bring in more oxygen and nutrients to supply the tissue. And that'll increase as long as the metabolism is increased. We call this kind of response an active hyperemia. It's active because the tissues are actively producing metabolites that cause dilation of arterioles and pre-capillary sphincters, and it results in increased flow. It differs a little bit from the other condition over here shown in B. This says reactive hyperemia. Over here, it just says active hyperemia. Over here, it says reactive hyperemia. It follows a period of decreased blood flow. If you were to put a blood pressure cuff around the arm, blow it up and restrict blood flow into the tissue, okay? Decreased tissue blood flow due to occlusion, like a blood pressure cuff. You'd have metabolic vasodilators being produced, similar to what was done over here. This is kind of artificial here, though. This will cause the arteries to dilate, but occlusion prevents blood flow. Then if you release the blood pressure cuff, the pressure on it, there's decreased resistance. There'll be increased blood flow. When the dilators are washed away, arterioles constrict and blood flow returns to its normal level. So these are what I call variations on a theme. This would occur naturally. This one I could get to occur in an unnatural way, but the underlying physiology is very similar. Okay, we're getting near the end. So local paracrine signaling and regulation of blood flow. Okay? Hypothetical capillary bed with some arterioles and smooth muscle and pre-capillary sphincters. Tissue levels of things like hydrogen, CO2, oxygen, and other ions and metabolites regulate smooth muscle contraction and therefore blood flow. So as they produce these metabolites, they regulate locally the smooth muscle around arterioles and pre-capillary sphincters. Decreased oxygen results in increased nitric oxide produced by the endothelium of these blood vessels. Nitric oxide is a vasodilator. It used to have a different name, and I'll get to that shortly, or next time maybe. But it's a gas produced by the endothelial cells in response to hypoxia, and it also causes relaxation of the smooth muscle. During inflammation, you get things like histamine and kinins that cause vasodilation. That's one of the reasons that during an inflammatory response, if you damage your skin, if you rake it across a file or a saw or something like that, it becomes inflamed, it gets red, you get increased edema, blood flow into the area. That's part of the reason for that. And then finally, another example, during blood coagulation, serotonin is released by platelets. This is part of the blood clotting mechanism, but the serotonin that release causes increased relaxation of smooth muscle and therefore increased blood flow. Finally, as a prelude, we're going to start talking about autonomic regulation of blood flow, and this will lead me into baroreceptor reflexes. This is an enormous overview that's being presented here, okay? Up above, we're showing arterial diameter is controlled by the tonic release of norepinephrine. Norepinephrine acts on alpha receptors residing in smooth muscle cell membranes to promote vasoconstriction. When you get increased nitric oxide release, it acts on actually alpha-2 receptors to cause constriction. When there's a reduction in norepinephrine, there's spontaneous relaxation or vasodilation, okay? Now, all of this down below, I'm going to talk about in nauseous detail as we go along, but it's an overview. Let me emphasize, that's an overview to illustrate how blood flow is regulated. And again, I will build on this cartoon to talk about the baroreceptor reflex. So much more of that is coming up, okay? I captured this text from page 489. I'd like for you to pay particular attention to this and study this. We begin to compare alpha and beta adrenergic receptors. Down below, I've said that arteriovenous anastomoses are regulated by alpha-2 adrenergic receptors. So the reason for wanting to know something about the different types of adrenergic receptors. I'm running out of time here. It's almost 2:30, and I'm going to have to stop to have our weekly recitation and review. So I'll pick up next time with this particular image here, but study this text very carefully. You can see I've reduced this. I've only got a few images to cover with you. I want to begin to talk about different types of adrenergic receptors. Alpha-2 receptors are the receptors that mediate sympathetic vasoconstriction. This next one I'm going to talk about, the beta-2 receptors, mediates dilation. So I'm going to stop at this point and have my weekly recitation with you guys. I'll pick up with this image next time and continue on.